Salmonella from all 4 types of animals, but Campylobacter we only got from chickens and only from one part of the country because that's what we could do. Well, after quite a bit of negotiation with USDA, and it took about 3 years to convince them that it needed to be changed, just to convince them that actually it was possible if we combined resources to get a good animal sampling scheme. And we met with a lot of resistance, if you will. But ultimately, we were able, working together, to come up with an entirely new approach to the animal sampling, which is to get intestinal sample contents at slaughter from all 4 animal classes and all 4 target organisms in NARMS. So we went from an old system, again, that was built because it was what was available, to a system designed for NARMS that is representative of national production, is randomly implemented, has all 4 organisms from all 4 animals, and we never had that before. So it's an important addition to NARMS that's already teaching us things we didn't know before. We've estimated in the U.S. that about 40% of Campylobacter cases are from chicken. Now that we're getting all these samples, we're starting to see a lot of isolates from humans that match the ones in cattle, which we didn't have the information to assess that before. So it's paying off in new ways beyond just measuring resistance, just to understand the status of our food supply and what's making people sick. So that was a big improvement, and the other part of it is we don't just have swine, but we have now different categories of swine. So now we can separate market hogs from sows and different types of cattle. We didn't have that level of information either. So that's another bit of improvement to the program. For a long time, we've had conversations about whether we needed to be on farm or whether it was possible to be on farm, especially if you want to build a program that you want to be representative. And we have a lot of farms in the United States and a very large production. In some cases, though, it could be possible. At least it could be possible if you sample at the right places. So I think there are 34 feedlots in the United States that are responsible for some 80% of cattle go through 34 feedlots. Your use guides is essentially the formal proposal to eliminate all production uses of antibiotics in the United States, and then guidance to industry on what their responsibilities were in that process. It updated the veterinary feed directive so that all antibiotics used on the farm now must come under the direction of a veterinarian. We still have antibiotics you can purchase over the counter without that oversight. We've heard about antimicrobial use, and we fall into that broad category of nations that has only one real data set on use, and that is annual sales by year by antimicrobial class, which is not the same thing as use surveillance. And so we're working to improve that situation as well. And of course, working with our international partners, especially PAHO in the last year and a half or so. It includes research activities. In FDA research, that largely means investigations to improve safety and efficacy of regulated products. That's what regulatory research means. We're not exploring the nature of the universe. It's very focused. And then surveillance. Surveillance is part of this, and I would say surveillance is really the foundation of this because it is the system by which we measure the nature of the problem, how it changes over time, and then the potential impact of anything we do to try to slow down resistance or reverse resistance. So doing surveillance correctly is very, very important. And in the United States, our national resistance monitoring system consists of the 3 main parts that WHO recommended now some 15 years ago, which is human clinical isolates of the pathogens under surveillance, their presence in the retail meat supply or any food product derived from animals in which there are antibiotics used, and then the animal population as well. So we're trying to understand the way in which different ecosystems overlap, really, if you get down to the biological explanation. But ultimately, we're trying to understand the public health impact of how these products are used and what ought to be done to make sure they're used safely, and ultimately that they can be used for a long time. I think if you take all the sectors involved in this issue and could put one statement out there that everybody would agree with, it would be, we preserve the life of these drugs. We keep them potent and so that we have them for the future. And in an integrated system, I think having that shared vision is one of the key things. There's a lot of talk about different interests among different parties and perhaps the perception that somebody's livelihood is under threat or a practitioner is going to be told how to practice their profession. All those things I think can be discussed in an open and honest way as long as we have this shared vision that we're trying to preserve the common good and the value of these resources. So I think that's worth mentioning. So in NARMS, the human isolates come from all 50 states in the United States, plus 4 local labs in some large cities. They get a proportion of Salmonella, Campylobacter, and other pathogens, which they test for antibiotic susceptibility. In the food supply, we have just 14 states and their public departments of health that are purchasing meats on a monthly basis. I'll show you how that works. We also get isolates from our import control programs that we test because they're available. And a lot of times, especially when you're starting the systems, you start exactly like that with what's available. And so you'll see that NARMS has evolved from a situation where it was the low-hanging fruit, as we've heard said, or it's based on what was pre-existing, what was already in place, but has since then has evolved to become more targeted to its intended purposes. And then the animal population, that work's done at the Department of Agriculture, and that system has changed most recently. So we have the Centers for Disease Control and the major public health institute in the country doing the human isolates. FDA is looking at the retail meat isolates from, remember, the perspective is the safety of these products. Retail meats actually fall under USDA as far as regular safety assessment. And then USDA looking at the animal population. This will be pretty obvious, but it's certainly important to know a few things about your national situation when you're starting out or planning to put a program together like this. And certainly one is, what are the pathogens that we need to be targeting? And along with that, are what are the commodities that we should be sampling that are the major source of these pathogens in human illness, and typically those that come from animals, because quite a few Salmonella come from sources other than food animals. So, but you have to sort of balance the different types of information that you're interested in. And from this graph, it's pretty obvious that in the U.S., as in many places, that Salmonella and Campylobacter are the most important bacterial causes of foodborne illness arising from food-producing animals. And there's some other data you can see here for other pathogens where, for example, with Listeria, the mortality may be very high, but the number of illnesses is fairly low compared to the others. Anyway, so you can see some of the other pathogens there. So the core sampling in our program is Salmonella and Campylobacter, as it is for most national programs. And at CDC, at USDA, and FDA, we all look at non-typhi Salmonella and Campylobacter. One of the reasons this program works, I think, is that the 3 agencies involved, and I want to make it clear, managing this collaboration with different agencies, with different mandates, different responsibilities, different role, if you will, in government, is no easier in the U.S. than it is anywhere else. But another way I think that it works, another reason that it works, is that the Department of Ag, CDC, and FDA sort of brand NARMS in their own way. So to CDC, NARMS isn't the post-approval surveillance of FDA-regulated products. That's what it means to FDA. To CDC, it's part of their broader public health responsibilities. And so they've put Shigella into their NARMS program. It doesn't help us understand the impact of antibiotics used in food-producing animals since it's not zoonotic, but it fits for them within the structure of their organization. E. coli 0157, I believe still is, the recommendation is that it not be treated with antibiotics if it's acquired, so resistance there, again, is not maybe the most important thing. It's more the prevalence of that in products. But CDC can get that strain, so they can get 0157, so at least they can get data on an E. coli from humans, and so on. So you can see that we sort of let each other describe NARMS in the context of their own mission, and we're all content to live with it that way, and it makes for a sort of ongoing negotiation about the identity of the program that so far we've been able to negotiate successfully. On the USDA and FDA part, we look at Enterococcus and E. coli as two commensal organisms. They serve multiple purposes. Enterococcus and both, first of all, are indications of fecal contamination, but Enterococcus gives us some idea of resistance to drugs with gram-positive activity, which is the majority of those used in production. And E. coli helps. We don't get Salmonella from that many different samples. We get E. coli from 80 to 90%. So we have a sample for resistance among the enterics by using E. coli, but we also have an idea of reservoirs of resistance that might spread to the pathogen. So it's valuable for those two reasons at least. Obviously, some E. coli are pathogens in their own right. So NARMS began in 1996. It began just with human Salmonella. That's how it started, and it was in 14 states in a new program at the time called FoodNet. And you can see that it's grown over time. 3 sites were added in 99, and by 2003, it's nationwide. So I think Enrique pointed out at the start today that it's not essential to do everything all at once, and it makes sense economically and organizationally to do it in stages. And so at the CDC, they're looking at non-typhi Salmonella. Currently, every 20th isolate that comes into the state public health department is sent to CDC. They do the antibiotic susceptibility testing. And you can see the other organisms that CDC includes in NARMS are listed here. So they do all the typhi. They do every 20th Shigella and O157. And Campylobacter is a little bit odd. It depends on the burden within the 10 states that are submitting isolates. And so Campylobacter is not nationwide, only Salmonella. And, it's been a point of discussion about whether that is something that we should change. For the retail meat surveillance, it works in partnership with the state labs. So we now have 3 federal agencies and 50 state labs who are part of NARMS, if you will. In 2013, we went from 11 states to 14 states. And this is how we do our retail meat sampling. It certainly doesn't apply to every situation, but we have every month in each of these states, people from the laboratory go out and purchase 10 packages each of the commodities that are most responsible for Campylobacter and Salmonella in the U.S., which is chicken, pork, turkey, and beef samples. So every month they purchase 10 of each of those, and all 14 states culture for the major pathogens, and then just 4 states culture for the commensal organisms, because we get so many. So it's a question of not being able to manage much more than that. So in the U.S. we have, in a country, I think there's 8 billion chickens a year, 100 million cattle on the hoof at any time. I've lost count of how many pigs, but that's what we get. We get 6,700 samples. I've come to accept the notion that the best surveillance system at the end of the day is the one that you can afford to put in place. I wish we had more samples. We need really more samples from retail meats to really be able to describe the trends in resistance in the retail meat isolates. The human isolate collection and the animal isolate collection are pretty good, but they weren't always that way. So when NARMS began with animal isolates in 1997, it was based on our HACCP system. So this is the processing plant hygienic control system that USDA operates to this day. And I know you're all familiar with HACCP controls. And it was just Salmonella. That's all that was part of our HACCP system. And so we got some. I could summarize this by saying that we've just finished it. We had some success, some failure, some companies, some production organizations were more interested in helping than others. It was a bit of a mixed success, I would say. Right now we're trying to take this feature of our surveillance system and also get USDA to try to lead that type of data gathering. And I can't say we've got a solution to it yet, much more than to organize the actors and agree on the importance of that piece of the surveillance data. The other important part of integration, and this was mentioned earlier, about doing not only the same sampling, but processing those samples in the same way, examining the organisms with comparable methods, and if they're not there, come up with them. I mean, it's that important. And so when I first came to FDA, I was surprised to discover there was no standard reference method for Campylobacter susceptibility testing, the number 2 cause of bacterial foodborne infection in our country. And so we weren't content with that. So we started multi-laboratory trials to develop a standardized method for Campylobacter, which became part of NARMS in 2005. And since then, we've all used the same methods for susceptibility testing. We share the same format of drugs on the panels. We share that with our partners in Canada, so we have comparable data. We participate in the same quality assurance programs, and we work closely with CLSI, which is our consensus standards organization. So we do whatever we can to make sure that in the laboratory we're generating data that's as comparable as possible. The other part of that, of course, is the lab, and I think it's worth emphasizing this technical side, the laboratory component of it. This shows the drugs that we test against Salmonella and E. coli and the breakpoints for resistance, and that we designed this panel so that we had a quality control for the method for every drug on the panel. So every time we ran it, we had quality control for every drug, and that's important because unfortunately, sometimes these data are used in legal proceedings, and so we have to make sure that the standards, the data quality standards, meet that legal challenge. But this is not to say that the only valid system is one based on measuring MICs. I think people have said that a lot. I don't agree with it personally. In fact, you could make an argument that disk diffusion susceptibility testing gives you more information than MIC data. I would simply say that, the other part of it is it's more expensive to get MIC than to get disk diffusion data. And I wouldn't let that stop anybody who's trying to start a system. If affordability is an issue, as it always is on the front end, using disk diffusion is fine. I would simply say collect the quantitative data, measure that zone size, and report those millimeters. Because just interpreting it as resistant or not, that you'll have a problem once those interpretations change, and they almost always do. Another part of harmonization, if you will, and integration is how to report that data. So we agree on how to generate it. There's been a lot of confusion about how to report it because resistance is a very charged word. It has, when you use that word, it means different things to different people. So historically, we've tried to report our data based on clinical breakpoints that CLSI has established. Well, CLSI is different than the European system. So you could leave the United States with a resistant infection and land in Europe and have a susceptible infection. And that's not a very good way to compare results from a surveillance system. So one possible way out of this is to just report organisms that are not part of the susceptible population, which is this population here. Just ignoring clinical breakpoints for a minute. So you could, and this is what we've moved to for Campylobacter. It's what the Europeans do. So this would be the definition of the susceptible population. Anything over here is resistant, whether or not it's clinically resistant. And so a lot of surveillance systems specifically are moving towards reporting organisms that have lost their wild type characteristics. So just quickly, I'll show you probably what's pretty obvious to most of you, but how we dig into the NARMS data and extract from it the information we need to fulfill our regulatory responsibilities, but also, to help CDC in its public health mission and USDA as well. And if you begin with the most obvious categories of information from Salmonella, they start with the serotype information, which sheds light on where these organisms are coming from that are infecting humans. And so you can see, for example, that this new typhimurium called I4512I that appeared most recently seems to come only from poultry sources. Typhimurium might come from any source, but Newport is mainly from cattle. And so if you're trying to understand not just the origin of a pathogen, but the origin of the resistance in that pathogen, serotype is a historically very useful way to examine it, as we all know. But it is a first piece of the puzzle. And then when you move to the important resistance patterns within the different serotypes to understand the burden of resistant infections in humans, of course, you can get an idea of the animal, attributing it to the animal source. Something that we see, and I think you probably see here also in Chile, is that Kentucky is very common in poultry, in chicken sources, but it's not at all a successful human pathogen. And this is something that we have to deal with in risk analysis. You've got an organism that's not a good pathogen, but may be quite resistant to an important class of drugs. So we're at the next layer of information, which is which serotypes have the resistance that is reaching humans. And then, of course, probably the most important thing from a regulatory standpoint is how is that resistance changing over time? And this just shows the main serotypes that are carrying ceftriax of resistance by serotype, from which we can infer animal source. And Heidelberg has been one that has been increasing in the US and Canada for some years. I don't have the most recent data, but the point is simply to show that the trend analysis is central to any regulatory decision making. So historically, along with the trends over time and the changes by year, this sort of summarizes most of what we've reported every year, and that is these little boxes represent the resistance to the different drugs on the panel I showed you, the state that it came from, the type of meat it came from, the date it was collected, and then the serotype. And this just happens to show the retail meat isolates, but human isolates are present throughout all these different patterns, and so you can see certain strains reaching the human population and causing illness. Then if we wanted to learn more about the resistance genes that are moving through from farm to humans, we would go do small studies like this little plasmid shows here, where we might sequence a few strains or look for specific genes that conferred resistance to important classes. But they weren't in our surveillance reports. They were part of research studies that came out much later. And so valuable information to be had from it, but too slow to be part of routine surveillance. One point I would really like to emphasize is that although NARMS was established to monitor resistance and established by FDA to monitor the safety, the efficacy of products, very soon you build a database of information that you can use for to answer questions beyond this original design. And this was made very clear recently in the United States when there was an outbreak of Salmonella Heidelberg infections that CDC was struggling to resolve. And then when they went and looked at our NARMS retail meat data and saw this pattern in there, which we had been generating these patterns for years, mostly for CDC purposes, it was instrumental in resolving one of the largest outbreaks in the history of the US, and it made us realize in a new way. I mean, we always knew that data was there for evaluation, but it seemed that it reached a point where now it became a major tool in outbreak investigation, which was never the original point of the program. But the data are rich, and the data say a lot about the microbial status of food and food animals. And so beyond, helping in outbreak detection, I mentioned it can help determine the burden of illness estimates for resistant or susceptible strains. But the isolates themselves, and I'm a microbiologist, so this is a microbiologist perspective, you can evaluate them for evolutionary relationships, how multi-drug resistance has evolved over time relative to the approval of new products, patterns of virulence, use them to develop methods for susceptibility testing or rapid detection. And of course, the program itself is now a very extensive network of trained and dedicated lab personnel and epidemiologists who are eager to solve the next problem. And so it has flexibility enough so that if a question comes up, is MRSA a foodborne pathogen? We can quickly go and do studies to try to answer some of those questions. And something we've not done but has been suggested to us is that we've got the infrastructure in place to go out and answer completely different questions, such as monitoring for avian or swine flu, since we're now looking routinely at animals in a nationally representative way. So the beauty of this type of program is it quickly becomes more valuable than it was designed to be, if you will. So we heard some comments earlier about whole genome sequencing and how that's changing things, and it's changing things very quickly and very dramatically, and it's going to change how we do surveillance in the future. And it's really not hypothetical anymore. The studies have been done to show that one method likely in the future will replace all these other methods that required training, specialized training, required specialized reagents, sometimes expensive instrumentation, that made the process very slow and held up reports. I think it's safe to predict that whole genome sequencing could do away with all that. We already know that we can, in the United States, identify over 95% of serotypes on sequence right now. We don't need to do classical serotyping, so we're cutting back on those reagents, which is, I think, still the #1 challenge in developing countries who want to do salmonella surveillance, is maintaining those typing serum. PFGE and other strain typing methods, like you know the alphabet soup of MLST and MLVA and on, are all going to be unnecessary. You can extract that information from the strain. We've done the comparisons of Campylobacter and Salmonella out of about 300 Salmonella that we've sequenced entirely and 120 Campylobacter that we've sequenced entirely. And you can predict resistance with the sequence data just as reliably as you can with phenotypic testing. So it looks like for at least our pathogens, someday we may not be doing in vivo testing, except maybe some sentinel drugs that we might be really especially interested in. And I think of this myself as it's really just deeper surveillance. We're now doing, if you will, nucleotide surveillance as opposed to a few phenotypes. And so it ought to be able to replace all of these things. We'll get virulence profiles. We'll get the equivalent of phage typing. The source attribution potential is fantastic. Our counterparts at FDA have used whole genome sequencing to go to a building in a different continent to identify where salmonella came from. It's just it's amazing what it can do. And it'll save a lot of money and allow us to look at more samples and get better information and make better decisions. So I think it's hard to overstate the promise that will bring to surveillance. So is it easy to do? Well, it's not easy to do. There's a lot of challenges with building integrated surveillance programs like this. It's expensive and it's a lot of hard work. There's no doubt about that. You do need some information to design a program suitable to local priorities. That is, information on consumption data, which we have here in Chile, and information on the sources of different bacterial pathogens. The sampling issue was raised earlier. Absolutely critical that you understand the consequences of where you're collecting samples, especially in the animal side, where you may get different profiles or different serotypes, whether you're on farm with swine or just getting off the truck at the processing facility. So it does matter. The big challenge is combining resistance and use data in a meaningful way, a way that we can describe with the appropriate language about risk. No small matter is the cooperation, collaboration, and good communication, data sharing between all of the actors and the principal players. Again, that's not a problem one solves. That's a challenge that is an ongoing negotiation and really relies on good relationships. Of course, it needs political. It's much easier to have those good relationships if you have the political recognition that this is worthy of resources in an environment where there are a lot of public health needs. The system itself has to recognize and try to build a culture of continuous improvement and review of the program and change and improve where you can. Understanding the implications of the data. Now, of course, this is a very challenging thing as well, where two people can look at the same set of information and draw very different conclusions. And so ultimately, though, the public health officials have to use that decision to take action. And the international piece is absolutely critical. We need to be able to compare data between different systems and describe our results in a common vocabulary. So that's the challenges and the difficult part, and I'm sure others could add to that list. But the benefits are tremendous as well. And I just list some of them here. For example, documenting resistance levels in different reservoirs, so you get a baseline understanding of resistance and where it might be coming from. And spread, and trends, and attribution, and using all of this to analyze risks. But you can take out this word resistance, and you've still got a very good monitoring system for public health and infection control, because you could be looking at different pathogen levels in different reservoirs and different pathogens and how they're spreading, and you can get all that information out of an integrated surveillance like this. And this is a key, this is really the reason it exists, is to guide evidence-based policies, science-based, show me the data-based policies, to try to control use and resistance in different environments. And then on the regulatory side, I mentioned we use it in the risk analysis procedure when we evaluate new animal antibiotics and post-harvest to look for potential problems. And then you go back to the top, and if there is a problem, you document those new baselines. And so the subtitle of my presentation is that this is a program for a platform for food safety, and I think that's one of the best benefits of it is we have been able to design a system in the United States, and as we'll hear in Canada and in Colombia and elsewhere, that serves the goals that it was set out to serve, but has since proved to be valuable beyond those original intentions, which has payoffs that help all of us do our jobs to serve public health. Thank you very much.